Welcome to this Author Hub webinar. Thank you so much for chiming in. This time it is the perfect hip replacement, and to help me run that, because I'm not a hip replacement guy, is Andrew Manktelow, awesome guy from Nottingham who is very well known throughout the field. Andrew, thank you so much for joining us. Take it away.
Thanks very much, Pete, and very grateful for this opportunity. And when we put this together, entitled it "The Perfect Hip Replacement," there's just so much to talk about, to be honest. So what I thought we should do really is to start with the basics, the things that really we should concentrate on in terms of technique. And so we wanted to talk about fixation of implants and really, before we get into the operation, to talk about planning. So that's the basic principles of what we wanted to spend the next 90 minutes talking about. So listen, I'm just delighted because we've got a fantastic group of colleagues and faculty that have spent time and joined us this evening. We have David Beverland from Belfast, who is one of the most experienced hip surgeons in the UK. Sam Hook from Portsmouth, again, with an excellent hip practice, busy surgeon. And Jonathan Howell from Exeter, who again, ex-president of the British Hip Society. And so people who really have got huge experience in hip replacement surgery and really have come from and used different technologies and different techniques to get the right result. So listen, what we're talking about here is trying to get better results for our patients. And there's no better place to start than with planning. That's a really, really important part of hip replacement. So that's what I thought we'd do first. And Jonathan, I've asked you to give a talk on planning for perfection.
Thanks, Andrew. I'll just share my screen. So let's get going on that. Hopefully you can see that all right. So it's an absolute privilege for me to be asked to talk about planning on this session. I'm deeply indebted to the organisers. So important to give you my disclosures. I'm a consultant for Stryker, and so I won't mention any prostheses during this presentation. So planning, why bother? Well, for me, planning is an absolute essential part of the procedure. I literally can't do a hip replacement without planning it beforehand. I would feel naked doing so. And that's for several reasons, really. First of all, the anatomy determines the function of the hip and the results that we get. And we've got to get some numbers right. We've got to hit the right center of rotation. We've got to get the offset of the hip correct if it's going to function properly. We've got to get the leg length right, because that's a common cause of medical legal problems post-operatively. And of course, our component sizes have got to be right. And all that needs to be planned. And then some time spent in planning helps to predict our needs in the operation, our needs for instruments, the prostheses and any special prostheses we might need. And also starts to make us think, how are we going to get to the hip and what surgical approach would be best for this patient? Some thinking beforehand reduces thinking time within the operation, and that helps reduce operating time. And that in turn will lead to fewer complications in terms of infection, because the wounds open in less time. And of course, some planning helps reduce other complications like dislocation. It acts for me like a warning system. If my plan, if I've planned before and if intraoperatively I'm not getting what I planned, then that's a warning sign that perhaps I'm not doing the operation quite right. I haven't got the access I need, and that causes me to pause for thought. So there's a heck of a lot involved in planning an operation, particularly a complex one. But in a short presentation like this, I'm literally going to concentrate on the templating, but that is far from the only aspect of planning an operation, as I'm sure you'll all know. And really what I'm going to do is just run through 6 steps that I use to assess every X-ray. That includes simple cases and more complex ones. So a 6-step approach, starting with an assessment of the X-rays. First of all, are they recent? And for me, that means within 3 months of the operation. I really have seen some problems where operations have been done on old X-rays, and I would advise 3 months. We use an AP pelvis for hips like this one. It shows more of the femur. That helps to show you where the femoral stem is going to go. We use a marker, as you'll see on the white arrow there. That helps to scale the hip replacement, make sure you've got the magnification right. And it's important to have the legs 15 degrees internally rotated if you can, because that shows the true offset. this is a good x-ray in my view, but these two x-rays are from that same patient. And you'll see on the right-hand side, that's with that lady's leg externally rotated. And you can see what that does in terms of foreshortening the offset and raising the center of rotation. So the second part of the approach is to assess the bone deficiency or excess. And if you've got a deficiency like this one, you want to know where it is and whether it's contained or uncontained. A horizontal line across the pelvis through the teardrops can help, because you put another parallel line through the roof of the other hip, and now you can see that hip on the right's got an uncontained superlateral defect, and that helps to start predict what our requirements for prostheses and bone graft is going to be. Bone excess is familiar to us all in terms of osteophytes, which can be medial, anterior, posterior, and even on the femur. And if there's been HO on another hip replacement, that's a warning sign you might get more. Other causes, of course, of bone excess, you can see this dysplastic case on the left has had shelf procedures. Those bony shelves tend to be anterior, and you're going to have to deal with those at the time of the operation if you're to avoid post-operative impingement and the risk of dislocation. So the third part of the six-step plan really is to measure leg length difference, and that's an absolute crucial thing to get right in the operation. On this X-ray on the left, you can see that there's some femoral osteonecrosis, some loss of the bone, and that's led to some shortening of the bone. We've used the horizontal pelvic line here again, and then measured down to a reproducible point on the femur on this X-ray, the top of the lesser trochanter, and you can see this patient's got a leg length difference of 10 millimeters, which we're going to need to restore in the operation. The fourth step is to establish the center of rotation of the acetabulum. This is crucial. We've got to put the cup in the right place if we're going to normalize the forces in the hip. With a cemented cup on the left-hand side, I use three basic landmarks. The first is the teardrop down below. I want the lower end of my cup to be at the level of the teardrop. The second is the ilioischial line, and I want the reamer shown here in the dotted line to be adjacent to the ilioischial line. And the third point is the superlateral part of the acetabulum. I want that to cover the prosthesis. And that helps me to size and position the acetabulum and then place the center of rotation, as you can see on the black mark. And really with an uncemented cup, it's a similar sort of position for me. I don't want to over medialize the cup. Perhaps this one has been planned a little distal, and perhaps I could raise it up a little bit. But it's the same sort of principles, really. In a robotic case, you get to do that in 3 dimensions. So the new prosthesis center of rotation is the green dot. The native hip was the magenta dot. And you get to be able to look at the front and the back of the hip replacement and see the coverage of the prosthesis that you're going to get. And that's a nice extra nuance to planning, and we can discuss that perhaps a bit later in the cases. The fifth step is to measure the femoral offset and size. So this is an offset of the stem, which is about 37.5. And you can see medial to that is the center of rotation of the acetabulum. So this offset of this stem is insufficient. It doesn't restore the offset of the hip. In contrast, if you put a 44 millimeter offset here, you can see that now overlaps the center of rotation of the acetabulum. And that's going to restore the offset nicely. And so that would be the stem that I would choose for this. An alternative way, if you've not planned where the acetabulum is going to be yet, is to just put the femoral prosthesis over the femur and put it straight down the femur, and then look to achieve what you can see on this X-ray, which is a concentric head within the center of the femoral head. And that really restores the femoral center of rotation and is the correct offset for this patient. In robotic planning, the center of the femoral component is the blue dot there, and you can see that overlying the green dot of the acetabular component. So that's going to be the correct center of rotation. And the robot also shows a yellow cement mantle there, so that also helps with sizing at the same time. On the normal acetates, you want the cemented stem to have a reasonable cement mantle. There's a number 3 on the left and a number 1 on the right. I'd say these are both, one's oversized, one's undersized, and the correct size should probably be between the two. And finally, the really important thing, I think, is to measure the depth of femoral insertion to restore leg length. We measure down from the greater trochanter to a line level with the shoulder once we're happy that we've got the position where we want. You can see it's about 15 mils on this X-ray on the right. And the technique then is to take that measurement and mark your rasp 15 mils from the shoulder up to a line, and then when you're placing that rasp intra-operatively, place that line opposite the greater trochanter shown with the arrow, and you'll absolutely restore the leg length. And that technique has been used in this paper from Glasgow that looked at this technique in restoring leg length, and the mean post-operative discrepancy reported in this paper was just 1.3 millimeters, which at the time that paper came out was the lowest leg length discrepancy in world literature. So it's a nice technique because the leg length, if you put the cup in the right place, the leg length is entirely dependent upon where you put that femoral component in terms of its height. If you want to make it longer, you leave the prosthesis out more. If you want to make it shorter, you can just sink the prosthesis a little bit further and you'll shorten the hip a little bit. So I think planning is an absolute integral part of the procedure. I think it can be done with acetates digitally or with robotics, and I hope I've given you 6 essential steps to follow to help plan getting your hips right. And if OrthoHub will just allow me to plug the forthcoming British Hip Society annual scientific meeting in June, please come along. It's going to be a lot of fun. Thank you very much indeed for listening.
That was awesome, Jonathan.
Thanks
very much. Just before we start, I'll hand over to you, Andrew. Just to our audience, you've got access to this awesome faculty here. Please communicate to us through the Q&A. Don't use chat, that's been disabled. Come through to us on Q&A and ask whatever questions you like, and we'll put them to the panel. So you've got the experts here. Hit them. Fire your questions in. Andrew.
Yeah, no, Jonathan, thanks very much. I mean, listen, let me put my hands up. I'm a planner. Okay, and sometimes you feel that others look at you when you're there with your acetates and you're there with your computers and you've done a few hip replacements before. Why is he still planning? I'm a planner. Sam, what about you? What are your thoughts?
Yeah, I'm definitely a planner. Like Jonathan, I can't do a hip replacement unless I've templated it and planned it and thought about it to the extent that I'll send the hip fracture back down to X-ray for a proper adequate film before I do their hip replacement. I think you've got to. It just means that you're prepared for whatever might happen during the operation.
And in terms of the X-rays that you get to plan, what do you send? What do you ask for from the X-ray department?
I asked for an AP hips plus templating, and then obviously for the elective hips, you also want a lateral hip as well, because you can get caught out if you haven't got a lateral. I don't worry about that particularly for the neck of femurs, but they've had one for the neck of femurs because that's all part of their their workup when they come in. But absolutely AP hips plus templating.
Okay, and they'll scale that for you with the templating, even with the hip fractures. I think that sometimes be a problem. David,
in my current trust, yes, yeah, they seem to do that routinely, which is great.
And David, what about you? Are you a planner after thousands and thousands?
It's as important as closing the wound, Andrew.
Right.
I love that.
I've got a nice question here from Hussein, who's saying, for patients with spinopelvic fusion, do you get sitting and standing X-rays, and how do you decide where to put the implant if you do get these X-rays? I think we're talking about sagittal balance here. Where does that come into things?
Yeah, I mean, I think that the spinopelvic relationship has obviously been of huge interest in the last few years, and in response to the literature and the growing knowledge, I have started to get standing and sitting X-rays of people who have had lumbar fusions, particularly, I would have to say, if the lumbar fusion extends onto the pelvis. I think you've got to look to see, obviously in a fusion which is fixed to the pelvis, the hip's not going to move much between sitting and standing. And then you've got to look at the position that the spine is being fused in. Are you dealing with a hyperlordotic spine, or one that has no lordosis at all? In other words, are you in the stuck standing position or stuck sitting? And then knowing that, you can start to plan where the hip is going to be more unstable. If you're dealing with the stuck standing, it's more likely to be out the front. If you're in a stuck sitting, it's more likely to come out the back. So then you start to think about modifying your prosthesis position in response to that. But these cases are a good indication, in my view, for also modifying the prosthesis that you use. So you might, particularly with a fusion to the pelvis, you might start to think about a dual mobility hip. To be honest with you, I'll leave it there.
Yeah, I agree, but I think that the key thing is it's very dangerous to plan your cup position based on that. I think spinopelvic fusion means it's a high-risk patient, and as Jonathan says, think about using dual mobility. I think it's dangerous to try and change your cup position.
Do you know what, David? That's exactly why I said I'll probably leave it there, because although that's what the papers say, that you're worried about coming out the front, coming back. When you come to it intraoperatively, it takes a lot of bravery, I think, to change the way you put your cup in based on that.
Yeah.
You
I think it's crazy.
Cause problems.
I think it's crazy. Yep.
Can I ask a question about, we've got some coming from the audience, but just in where we are at the moment with our waiting lists, patients have waited for an awful long time. Some people have had operations planned this time 5 months ago. We're certainly seeing some interesting looking x-rays now. So what is the panel's policy on how near to the surgery would you want to get that planning x-ray?
Well, that's really interesting, Andrew, because this afternoon I got challenged in outpatients. I've got a patient on Monday who had some superlateral wear on an x-ray 3 months ago. And a patient came to preoperative assessment today, and I asked the fellow to get a new x-ray for Monday. And, I called into the x-ray department this afternoon and said, why justify this x-ray? One was done 3 months ago. And I said, I'll tell you why I justify it, because I've seen these go, and they go rapidly. And so, I don't want to get in there on Monday and find, get caught. And so, I was able to justify, and they were perfectly happy. But so I think if there is acetabular wear, then I'd foreshorten that three months. Sorry, Peter's got some questions, I think.
And we should move on to the next bit.
Okay.
Well, thanks very much indeed. A great start. So we're going to start talking about fixation, and I've asked Sam just to sort of enlighten us on something that I find quite difficult. That's how to cement a socket. Quite a difficult skill. And Sam, can you tell us exactly how we should be doing it?
Yeah, I can. Let me just share my screen. So can everyone see that? So thank you, Andrew. Thank you for, and also for inviting me to talk on this webinar. So as I say, I've been asked to talk about how to cement a socket, and given the title, Truly Not a Mystery. So I'm going to try and demystify this for you all. So here are my disclosures. I've got an educational contract with Stryker. So cementing a socket, well, it's a bit of a dying art. You can see from this most recent NJR data, a table of fixation by year, that actually you can see that for the last 5 years, the number of cemented, all fully cemented hips, so the purple line has been steadily declining. In contrast, hybrids are steadily increasing. And I think you can also see that the uncemented fixation is steadily declining. So it seems that we're happy to cement femurs, but we're not nearly as happy to cement cups, and that is a bit of a dying art. So why is it a dying art? What makes people not want to do it? Well, I think that people feel that it takes too long, that there's lots of fiddly little steps, that perhaps that extra time waiting for the cement and performing those little steps is the difference between getting another case done or not, and so their workload. I think people feel it's messy, that I think they feel that these hips fail early, that cemented sockets don't do well, and frankly, it's just too difficult. And I've also heard people say that cement kills, and they talk about cement killing patients, and they talk about cement killing the bone. That said, I'd argue actually that cemented socket fixation has a lot of positives, and to name a few, I think you can get more accurate placement of your socket in your target zone, in your planned position. And there's a very nice paper from Ross Crawford in Australia in 2009 in the Journal of Arthroplasty, where he reviewed a series of his hips with both cemented and uncemented sockets. He placed a socket in his desired pre-planned target zone. And then he used an imageless navigation system to look at exactly where those sockets were once they'd been implanted. And actually what he showed was there was significant deviation from his planned and desired target on the uncemented sockets, but the cemented sockets pretty much hit his target most of the time. So actually he reliably could place his cemented socket exactly where he wanted it. I think I'd also argue that it protects osteoporotic bone. So, you know, you're not hitting in and implanting a big solid bit of metal into that fragile osteoporotic bone. So I think it has benefits there. And actually, I think we'll see that it has excellent survivorship. So this is just a table from the NJR, lots of data on it. That's not the important bit, but you can see, looking at the cumulative revision rates over the years, you can see that actually the fully cemented implants and the hybrid fixations actually have a very similar revision rate at that 15-year mark, which is significantly lower than the fully uncemented implants. And I think you can take from that data that actually it's not the cemented sockets that are failing. They clearly must be doing well. So I think we can't say that they fail early. So in terms of doing a cemented socket, I'm just going to run through some of the sort of the key parts of it with a series of little videos. So we're just going to start off by talking about reaming. So obviously you will have exposed your socket, you'll have found your true floor, and you'll be starting to ream up sequentially with your reamers. And you just see here just reaming, and what you'll notice is actually the reamer's being moved around quite a lot. So actually one of the benefits, I think, of a cemented socket that makes it, I think, quite nice and easy is you don't have to hold your reamer in an absolutely perfectly still position. So long as you're not reaming out the rim, you're not creating a segmental defect. Actually, this enables you to get all those sclerotic bits of bone. And you can see, even though it's been moved around a little bit, you can see there's still some sclerotic patches amongst that bleeding bone. So now what's happening is we're just taking a smaller reamer and doing a bit of focal reaming just to take away those white sclerotic bits to get down to that nice bleeding trabecular bone that's going to provide that perfect cementing bed. So you can just see, taking it in and out, just checking where the sclerotic patches are, doing lots of little bits of focal reaming, but not damaging the rim at all. The rim is still staying intact. You may have expanded the cavity a little bit, but that doesn't matter, because actually you're going to fill that up with that lovely cement. So the next stage is the keyholes, and I think people get a bit twitched about this, but actually it's really straightforward and simple. So first of all, just making some with a high-speed burr, just little ones around the periphery, and then comes the big scary drill that people are scared of. But actually, it's just about putting these drill holes, these holes in the weight-bearing area of your socket, in that safe zone, and they're exactly where you'd put your screws if you were augmenting an uncemented socket. And what they're doing is they're just providing a nice hole that actually your cement can be pressurized into and provide some additional mechanical interlock. And so the next step is you better just check those holes that you haven't gone through. So just probing with a curved artery clip, just checking there's a solid base to them all, so that when you push that cement into the socket and pressurize it in, that you're not going to squeeze cement into the pelvis. And this is just an instrument called the sucker aspirator going in. What you do is you put it over the superior aspect of the acetabula, and you can attach your sucker to that when you're washing to help pull some of the suction wash out of the socket, but also to help pull your cement almost into the trabecular bone when you're pressurizing and inserting your implant. And it really helps with that fixation and hopefully that survivorship of your implant. You do have to be careful that you don't suck too much blood out of the pelvis. So I'm very careful about which patients I use it in, and frail little old ladies with protic bone is a bad idea. So we wash a lot in cemented fixation. It's really important to wash the socket thoroughly. You want it to go from that bleeding cancellous bone to that nice white honeycomb bone that's going to take that cement beautifully and get that mechanical interlock and get that fixation you want. So washing really thoroughly, then just packing the socket with some saline soaked gauze, just soaking it a little bit, stops it catching on the trabecular bone, packing that in. while the cement's being prepared. And you can see the sucker aspirator again, that will have the suction attached to it just to help dry that socket and then help with the cementing. So the next bit is getting ready for the pressurization, and you'll see when the video starts that the trabecular bone at the bottom looks really nice and white from that cleaning, washing, and then packing with the cement, with the swabs. You need to put a bit of cement in. We tend to do it by getting the cement pumped out onto a packet and then scooping up a ball and then popping it into the socket. Then you can get your cement in really quickly and then get your pressurization seal on. And it's about choosing the right amount of cement so it's not messy. You can see a nice white bone, popping that cement in. You can see it's quite doughy, so it's not messy. It's not sticking to the surgeon's hand. Just peeled off a tiny bit so there's not too much in there. Putting that sorbethane seal on, handing it to the assistant, just getting them to lean on it whilst it pressurizes. And you can see there's a bit of blood in that sucker aspirator, so they've taken that off so as not to take too much blood out of the patient. Just tidying up a little bit, waiting for the point where they're ready to put the socket in. So the next step is when your cement's at the point for socket insertion, you then can get on and do that. So a little dab with a swab on a stick just to make sure it's all dry, and then pushing that socket into that pressurized cement. So here you actually start putting the cup in a really closed position, pushing it all the way down to the true floor, to the TAL you probably used as your landmark, or partly used as your landmark, and then pushing directly into the dome of the socket to then really bottom that socket out and make sure it's fully medialized. And then you just scrape away any excess cement. And you can see there is a little bit of cement that gets squeezed out inevitably, but it's nice and doughy, so actually it's not messy, it doesn't smear everything, it just comes out in a nice blob, and you can then just discard that. And then just the finishing touches. So when you're happy with your position, you take your introducer off, and then you just pop your cup pressurizer in, your pusher in, and get your assistant to hold that while you just tidy up around the edges, tidy up any tiny little loose bits of cement. And then you can see that that's seated beautifully, looking really nice. And then you can always take off a little bit of osteophyte if there's any left at the end. So actually, I would say that cemented cups are actually really simple. Yes, there are a number of steps. But if you do it the same way every time, if you stick to your principles, if you stick to your steps, actually you can do it simply, easily, elegantly, with no mess. You never need to get cement smeared all over your gloves. And actually you can get a really nice result with really good long-term survivorship of your implant. And like anything, practice makes perfect. So the more you do, the better you'll get, and the more you'll enjoy them. So thank you.
Thanks very much, Sam. So I'm going to talk a little bit now about uncemented sockets. So I'm going to share my screen there. And as Pete was saying earlier on, we're looking forward to questions. They're gathering. We've got lots of people joining us. And I think this is really where we're going to talk about the practicalities of hip surgery. So really send your questions in. So I'm going to talk about uncemented socket fixation and stick very practically from that point of view. Those are my disclosures. I was involved in design of one of these, and so that's why that's relevant. In terms of the principles, what we need to do just with anything is to make sure we get adequate exposure. We're going to carefully prepare the bone. We're going to make sure that we're going to individualize and plan our alignment to make sure that it's perfect. We need to make sure that our implant is stable, so we'll get good bony ingrowth into it. We need to be very careful with our liner insertion and make sure we get that bit right, so that we can get the biomechanics that Jonathan's already told us about and make sure our patients can get an excellent return to function and reliable longevity. So the first lesson is with regard to uncemented sockets is you must know your socket. You need to know about its geometry in terms of whether it's hemispherical or peripherally expanded. It's really important to understand the relationship between the reamer size, the socket size, and the trial size to make sure that you can make these things work. You need to make sure that you understand the reaming technique and the amount of press fit that you want to get in different quality of bone and in different circumstances. What is stability? How stable does it need to be in terms of getting good ingrowth? You need to get that through experience, and then when you need to use screws just to augment that stability to encourage bony ingrowth. You need to understand the different back surfaces so that you can use different back surfaces in different circumstances, and you need to learn to trust that back surface. So whatever you do, exposure is where it starts. You must have adequate exposure of the acetabulum, whichever approach. Judicious use of retractors and release so that you can see the acetabulum. You need to then identify the landmarks that Jonathan's talked to us about in terms of the teardrop, in terms of the true flaw. You need to look for osteophytes that you might have already realized are going to cause a trouble. And specifically from that point of view, in this particular case, you can see circumferential peripheral osteophytes that we'll need to actually remove before we start to get working on that acetabulum to make sure that we can see what we need to see. Then it's time for a stop moment. We need to make sure that we're going to review that plan that we've talked about, review the landmarks so we know where the socket's going to go. We're going to consider the bone quality. We're going to consider the anatomy to make sure that we're going to get this right. Now, there are different ways of reaming. Some will ream medial and then expand. Others will go straight to the side that they're going to use. But in essence, the basic principles are we're going to want to create a hemispherical socket in subchondral healthy bleeding bone that we can get a stable uncemented socket into and get bony ingrowth. There are lots of considerations in our planning and in terms of our technique to do with the abduction, to do with the anteversion that we're going to look at, how deep we want to ream that socket in to get the biomechanics right. We're going to see whether we're going to have an influence of femoral alignment on our socket position. And we should use these trials to rehearse the implantation. Very, very important part of that operation. So we get down, as you can see in the pictures there, to healthy bleeding bone that we're going to get our implant to go onto. Before we actually put the socket in, the final check, clear that peripheral soft tissue. Now, all of my fellows have got nicknames and names after them. And so all of these little lesions are named after different fellows, but we clear that soft tissue from around the rim. You'll see that reamers don't ream right to the rim. So you can get a sclerotic rim of bone around the periphery of the socket. And if your socket engages underneath that, it can change the orientation. So you need to get round there to make sure that you get back to a nice hemisphere and that your socket in position is not going to be influenced by those rims. When you go to put the socket in, keep the back surface clean and dry, and no touch technique. Make sure if you're going to use screw holes that they're orientated in the correct position, and use an alignment guide to make sure the components are right. And when you put the component in, you can just gently tease that past the soft tissues. It doesn't have to be introduced in the exact orientation that you're going to plan to put it in. Get it past the soft tissues into the socket, and then ease it down into the position that you want and get an initial press fit before you check it, and then finally seat the component home. In terms of final checks, we need to make sure the socket is against host bone in terms of depth. We need to make sure that it's aligned exactly as Jonathan had thought we were going to with our planning. We make sure that it's covered particularly anteriorly so we don't end up irritating the psoas tendon. We look for the osteophytes that we need to clear to make sure that we don't have an impingement concern. So in terms of tips for perfection, know your implant, fastidious preparation, attention to the periphery of the shell and to the peripherals of the socket there. Make sure that you use your plan to reassure you that you've got everything where you expect it to be. Have careful, consistent and accurate technique. Trust that back surface and do those final checks before you move on. It's really important that we get this bit right first time. I kind of feel we should have had that for ourselves rather than for the politics. Get this operation right. Thanks for your attention. We're going to move on now and have a discussion. I've talked a little bit about the Uncemented, with fantastic talk there from Sam. I don't know if there are questions from the audience, or Jonathan and David, any comments?
Yeah, there is a couple of questions that I think it's worth putting to you both. So one of them says that the person's a bit unclear. Should they ream to the socket for the bleeding cancellous bone or a subchondral plate, non-bleeding bone? So there's differences in cemented and uncemented. So I'll come to you, Sam. When reaming the cemented socket, what do you look for?
So I'm looking for that bleeding cancellous bone. I think you have to remove that subchondral plate, because what you're looking for is that sort of honeycomb trabecular bone that you're going to squeeze that cement into. You want the cement to go into that trabecular bone. That's where you're getting your mechanical interlock. That's where you're getting your survival of your implant and your stability of your implant. So that's what I would do for a cemented socket.
And Andrew, uncemented?
Yeah, so for me, I'm not going to go that far. If I've gone that far, I may have gone too far. So I'm going to get through the articular cartilage. I'm going to get into the sort of the sclerotic bone, and I'm just going to want to freshen that up into sort of punctate bleeding bone that still has some structural integrity, that I'm confident that I can get bony ingrowth into my uncemented socket. And again, from my point of view, I'm not that desperately keen always to ream too medially. That little extra millimetre of bone may be the millimetre of bone that explant will take that socket out with, and still gives me plenty of bone for another occasion. So I try and preserve that acetabular bone. I loved Sam's presentation of that, the appearance that you need for cement, but it's possibly not the same for an uncemented socket.
Peter, have I got time for another question? Okay, that's great. Greetings from Canada from one of the attendees. Advice on the small patient, please. Templates at the lower end of your system. I tend to have a backup implant, but I'm conscious of trading off head cup sizes for long-term bearing wear. Any pearls of wisdom from either of you, particularly maybe on the acetabular side, that trade-off between component size and head size? How do you approach it, maybe in different ages?
Well, I mean, I think first and foremost, planning is really important with that, because going into the operating theatre with your standard range of sockets of any type, and then finding out that you've got a tiny pelvis is an embarrassing situation to be in. So templating is important. On the uncemented side, there are some very small uncemented sockets that you can use. Again, I would go back to basic principles that you need enough polyethylene we're obviously more reassured by cross-linking and maybe vitamin E, but at the same time you do need adequate polyethylene thickness, especially in a young patient. And if that means a slightly smaller head size, well, there are other ways that you can make sure you've got that hip pretty right. So I sort of stick to similar ratios, really, whatever the side of the pelvis.
Yeah, I agree. I mean, I try and keep away from the 22 head if I can, just because that risk of dislocation, you know. I mean, obviously in the dysplastic and the really small patient, you've got to go for that. But I try and keep away if I can. And sometimes I will, you know, go for a thinner polyethylene just to get the 28 or preferably a 32 head in, frankly. Sam, any change, difference to that?
No, I think very similar. I think wafer thin poly makes me nervous. And actually, if you've got your planning right and your execution right, then the difference between a 28 head and a 32 head should not maybe making you think, oh my God, I'm going to put 28 and it's going to dislocate. Actually, you know, your execution should be good enough that a 28 head is perfectly acceptable. You know, and actually with a cemented socket that you and I use, actually, if you can only get a 46 outer diameter socket in, you have to go to 28. And I would much rather do that than ream too much to get a 32 in and then not leave yourself with enough bone and potentially scupper any other operations in the future, etc. I think 28 head is fine, and 22 if you have to, that's all right.
Andrew, I'll come back to you in a sec, but David, any pearls on this?
No, I agree with that. I'm happy to use a 28 head. I mean, there's a slightly higher risk of dislocation, but it's pretty minimal.
Yeah.
So the key is getting to 28,
Yeah.
and certainly there's no evidence above 32.
No.
So I think, you know, going for really thin poly with a 36 is not a good idea.
I agree.
Stick to 32.
Yeah.
That's maximum.
Thank you, David.
Can I just come in on that? Listen, you know, David just come in on a question there, but we've got David here. This is David, you popularized the transverse acetabular ligament, and it's important in primary surgery. Sam's alluded to it. I have alluded to it, but let's hear from you, David. You know, what is the importance of that, and where did it come from in the evidence?
Well, it came from the fact that my dislocation rate in primaries was 5%. And if you're doing over 500 hips a year, that's a lot of headaches. That was the history. So I was desperate. But essentially, the femoral head articulates against the towel. It's a load-bearing ligament. It's very, very strong. So if your cup articulates against it, you restore acetabular height. But every reamer must engage with it. If you start high, you'll never get back down again. You must keep every reamer against towel. The other key thing then is keeping your cup size a maximum of 4 mil bigger, because again that restores your joint center. And the other key then that you've all mentioned a little bit is not reaming to true floor, especially in big males. So I mean, male depth goes up to 15 mil, but 1/5 of males have a floor depth 10 mils or above. And if you ream to true flow in those ones, then you lose a lot of acetabular offset. So that's important. Simply then, so the towel controls version. So I think the key to version is the towel, but it's not that good on inclination. And the key to inclination is the pelvic sagittal plane. So it's how you set your patient up. So the sagittal plane is the key to inclination, and the towel is the key to version. And keeping against towel and making sure your cup size isn't too big controls your joint center. And in large males, don't go to the true floor. That's it.
David, I mean, that's exactly what I'd answer you. But when that towel area is calcified, you've got inferior osteophytes, and what's your tips for finding it and digging it out? Yeah.
So, I mean, the numbers are, so when you open a hip, half of them you see towel. A third are covered in soft tissue, which you can take off fairly easily, and the rest are what we call grade 3, which means covered in bone. And the key thing then is not to use an osteotome. Because if you you destroy it. So you take a small reamer and you ream in the opposite direction to normal, and you ream and look until the fibers appear. And once the fibers appear, I then take a marker pen and I mark the skin parallel to them. Because if it's a really bad grade 3, then you can end up losing them. So once you see them, mark them. And the same tip too in the very obese patient. You use a marker pen to mark towel on the skin. And it means then when you're reaming and putting your cup in, you have an external landmark, because in the obese patient, it can be hard to see.
So I was recently with Sarah Muirhead-Ord, who credited you with that, and she was marking on the skin. So you never stop learning, which is absolutely fantastic, a really key message. So that's brilliant. We're almost to time. We're getting going with discussions. We've got questions and answers coming. So we're going to move on to the femoral side now. And indeed, Sam, I'm going to start with you again and really talk about cementing the femur. And I've called it calm and consistent, because that's what I think it needs to be. And hopefully you're going to show us calm and consistent. Sam.
Thank you. Lovely. So thank you. Yes, I'm going to talk about how to cement your femur. And as Andrew said, it is calm and consistent. Actually, if you try and do this in a hurry, if you try and rush the steps, if you don't know your implant, if you don't know your cement, actually it can become a bit of a panic. But actually, if you know those things and you remain calm, you can do it really, really nicely with no panic. So my disclosures again. So as we saw in the last talk, actually hybrid fixation is increasing year on year in the UK. So actually cemented femoral fixation is a resurrecting art as opposed to a dying art. Certainly in some countries, certainly in this country, and certainly in the Swedish registry, you can see that they cement a lot of their stems. And I think in the NGR in 2020, over 50% of stems that had been recorded were cemented. That is in quite stark contrast to some data I found for the American Joint Registry, which was from 2016, so 5 years ago, but probably reasonably useful, where 96.7% of their stems were cementless. Now that is 5 years ago, and actually that was only capturing 25% of the data, but a big contrast to our use of cupped in this country, our use of stems in this country. So as with the socket, I'm going to work through this step by step, again with a series of lots of little videos, just showing some of the crucial points. Now you'll see from this slide here that actually one of the steps appears multiple times, so the washing part of this procedure appears often, and I think washing your canal in a cemented femoral component is really, really important in terms of achieving the right quality of bone for cementing and ultimately the survivorship of the implant. Now just the other day a trainee said to me, I wasn't allowed to wash the femur until we'd put the plug in and we were about to start cementing, and she asked why and was told it's because you push debris into the canal and that can cause problems. Now, I would argue completely the opposite. Actually, washing is really important. At every stage, you push an instrument down the femur to reduce that risk of pushing debris, fat into the systemic circulation and causing potential problems. So I would advocate that every time you instrument the canal, you should then thoroughly wash with pulse lavage afterwards to reduce that risk. We'll start off by talking about the entry point and the reamer. So assuming you've exposed your femur, you know your entry point for your particular implant, and it's just about getting that point right and putting the pin reamer down. So actually using an angled nibber is quite useful for getting that little hard bit of bone right in that posterolateral slot for the entry point for most cemented implants. And actually that little bit of hard bone can often push your stem into varus. So it's quite important to try and get that little bit. And you can see when they're putting the pin reamer up and down, actually they're putting it posterolaterally into that little slot to try and get that little bit of bone and get that entry point perfect. Now the next step after this would be to thoroughly pulse lavage the canal. So the next step is rasping the reamer. So you've obviously from your preoperative planning decided what size implant you're going to need and the offset. So you know which implant and rasp you're trying to achieve to then trial off. So I have to say I tend to start with the smallest rasp. I use that because I think it's just a little bit easier to handle. And I use that to rasp into that posterolateral slot to get that hard little bit of bone that can push you into varus, particularly when they've got an overhanging trochanter. So I start with that one, and then I work up to sequentially to the size that I need. So using the little one, just rasping into that posterolateral slot and just using that to just gently open up the canal, just tapping that down. You can see even though that canal has been washed probably several times already, there's still a lot of fat and blood coming out. So after this one comes out, that they would wash again. And then this rasp going in now is the one that is the one they're going to trial off. So just tapping it down to using that stem insertion depth that Jonathan talked about in the first talk to the position where you think you're going to put your definitive implant so you can then trial. And then you're going to wash before you start putting your implant in. So thorough pulse lavage. See all that blood and fat still coming out despite the fact that canal's been washed a lot. And you can see actually now that the cancellous bone looks nice and white and clean. Popping a suction catheter down and then just packing that canal with some saline soaked gauze just to stop it from filling up with blood from the base and reduce that back bleeding pressure and make sure that bone stays nice and dry for the cementing procedure. So now that bone's nice and dry and clean, the next step is to get your cement in pretty quickly. And obviously the canal has been plugged. So the next step is the cementing. So I think this is the bit where people then start to panic. Oh, I've got to get my cement in really quickly, and then I've got to quickly pressurize it, and then I've got to quickly get my stem in, otherwise I'll run out of time and the stem will get stuck out. I would argue that this is the point where you need to be really calm and really consistent and actually know your cement and know your timings. And that will vary depending on a lot of things, and in particular, the type of cement you're using. So the key here is I see people having been taught to put their thumb over the proximal femur, over the calcar as they're injecting the cement. You do not need to do that. That has absolutely no benefit. All that happens is you get cement on your gloves, and it doesn't provide any additional proximal femoral pressurization because you don't need to do that at that point. So I think you need to put your nozzle all the way down the canal as far as you can to the plug. Sometimes that's difficult in the tight canals, but you get it down as far as you can. And then it's about timing. It's about injecting the cement and pulling back on the gun at the right rate such that you're layering the cement up the canal of the femur, such that when your nozzle gets to the proximal femur and you're about to come out, your canal is full of cement, and you'll see that there's absolutely no mess. So just nozzle going in right the way down, starting to inject. Your assistant is pulling the suction catheter out once it gets to the point that it's blocked, and you can see that the cement is filling up the canal and the nozzle is out, and there's a tiny little bit of seepage, but there's no mess. Pressurizer going on, and then you just lean on that and pressurize that until the appropriate time, based on how your cement feels, the temperature of theatre, the cement you're using, and various factors. And you can see that even though that canal's been thoroughly washed, there's still a little bit of blood and fat coming out, and that shows actually you've got really nice pressurization as well, because you're squeezing that fat out. So then stem insertion. So you've got loads of time. Don't panic. If you know your timings, you can get this in and it will look really elegant as you put it in. So this is the point that you need to put your thumb over the calcar to provide that extra proximal femoral pressurization and improve the stability of the implant. So pressurizer comes off. Tip of the stem in the center of the femur. You don't need to go lateral with that. It's going to end up in the center of the canal, so you start it in the center of the canal. Push your stem down nice and calm and controlled. Stop a little bit from your planned depth of insertion just to check your version, just to check where you are. Clear a little bit of the cement off. It's a little bit further to go. You can see they just sunk another one of those laser marks. Cement's gone nice and doughy, so there's actually minimal wobble of the implant. Carefully take the introducer off, and then you can start to clear your cement. But you can see that was pushed in really smoothly and really calmly, and actually there's very minimal mess. Yes, there's been some cement leakage, but because it's nice and doughy, that will scrape off really easily and there won't be any mess. So again, like before, just the finishing touches. So carefully removing the introducer, holding the trunnion as you do it so you don't rotate the stem, and then just removing that little bit of excess cement. You can see it's nice and doughy. It's just coming away really easily and leaving a nice clean top to the stem. If when you're inserting your stem with your thumb over the calcar, it's starting to get a little bit scary and you can't quite get it down, really easy, just move your thumb and then you can push it down more easily. So again, my summary is the same as for the socket. If you know your implant, you know your cement, you work with it a lot, you follow the same steps and the same routine every time. It's simple, it's elegant, and you'll grow to love a cemented stem, and you'll never look back. It will be the thing that you always want to do.
Thanks very much indeed, Sam. We're getting some great questions. We're trying to answer your questions online with the Q&A. I hope you're getting some of those answers too. There's a couple that we'll come back to, but we've got so much to talk about, and we're going to now move on to uncemented fixation. Absolute great pleasure to have David Beverland with us, who's written about and has got as much experience as anyone of this. David, I've called this talk as simple as it looks because I'm not sure that it is. Tell us.
Thank you. That was very nice, Sam. Very good. Yeah, so as simple as it looks, I'm not sure about that. No. Why isn't this good? Yeah, okay. So my disclosure, so that my important disclosure is obviously that I work with DePuy. So these are my 10 steps. And again, it's based on my experience with the Corail stem. So pre-op templating, exposure of the femur, intraoperative measurements of head height and offset, entry point to the canal, broaching the femur, trial reduction, calcar reaming and checking for a fracture, retesting relational stability, stem insertion, and finally head impaction. So pre-op templating. So I want 5 bits of information. Number 1, femoral head diameter. So, and if you use a caliper to measure a head diameter during surgery, this is a very simple way of determining if your calibration is correct. Canal diameter, very simple and quick to do. If the canal is 10 or less, then I ream the canal to 10 millimeters. I want to know the predicted size of the stem, the approximate level of cut relative to lesser trochanter. Is it likely to be a high offset? Predicted size of the Corail stem is really important. So it's important with the Corail not to undersize. And this is a key message in this talk, to really avoid sizes 8 and 9 stems with the Corail in male patients. And in the Australian registry, if you use a size 8 or 9 in a male, your risk of revision increases by 6-fold. With regard to templating, we recommend you template line to line. So for example, if it's a size 12 is line to line, then you subtract 1 size and use a size 11. So canal fill -1. Is it likely to be a high offset? And we all know that external rotation changes offset. But what's not realized is that with external rotation, there's always some degree of fixed flexion. So this is a true AP of a normal femur. And you can see that head center is 12 mils below tip of trochanter. This is the same true AP pelvis. And these are 8 other views of the same femur with flexion up the y-axis and external rotation across the x-axis. And this is a fairly typical X-ray appearance pre-op. And if you see hip center at the tip of trochanter, then rather than being a valgus hip, that is projectional in 499 cases out of 500. And what that means in pre-op planning is, so again, A is a normal femur, and B is a normal true AP, and B is that same femur in 20 degrees of external rotation and 20 degrees of flexion, fairly modest. The next shaft angle changes from 125 to 135. The offset comes down from 42 to 35. But from the head center goes north by 12 millimeters. And if you reference off lesser trochanter, that will give you an error of 7.4 mil. Exposure to the femur, whatever approach you use, you just must see the femur well. I use a posterior approach, easy to teach, easy to learn, and it gives you good exposure, like other approaches do. Intraoperative measurements of head height and offset prior to head resection. And you need some method of determining the level of neck resection. And as Jonathan said, a long leg is caused by a high neck cut. It's as simple as that. And it's one of the most common errors, particularly in female patients. For 30 years, I've used a caliper, but involved arithmetic, and that never really became popular outside Belfast. But from January next year, the Q ring will be available for the Corail. It's very simple to use and no arithmetic. So these are the two Q rings. One is for standard offset, one for high offset, and you just flip over for left and right. The ring simply finds head center, and the rest of the Q finds your neck resection level. And you simply use a chisel to mark that and then make your neck cut. Having made your neck cut, just look at the AP dimension. And if it's narrow, then those are the ones that have a high risk of fracture, even with a normal canal. So a calcar fracture is caused by a narrow neck, not a narrow canal. The way around it is to simply always use a collar. And even if you get a crack, then the collar prevents the propagation. Entry point to the canal, very important, but often incorrect. This is a posterior approach to right hip, calcar here, posterior cortex, anterior cortex, and the trochanteric fossa. I use bone nibblers, and then I use an 8 millimeter reamer. Now that's a canal finder. It's not being used as a reamer. But as I've said, if the canal is 10 or less, then I ream that canal to 10. But that should be apparent on the preoperative X-ray. You should not find a narrow canal during surgery. As we said, templating is critical. And this simple rule for reaming the canal has allowed us to use the Corail in over 6,000 consecutive cases. So that's all ages and all door types. You can see in this X-ray here, the stem is in varus. The trochanteric fossa is still intact. And saying that the Corail is tolerant of malposition is the wrong message if you want 100% success. And note that 1 degree of varus will increase your offset by 1.5 mil. Here we have 9 degrees, which is 13.5 mils. Broaching the femur, simply with a cement-less stem, you have to stick to the version of the femur. You can't safely change version, you'll risk a fracture. Trial reduction. So with a Corail, when you add on the short and long necks, you have a huge area, but this is my thumb. And as you can see, my thumb is more than twice the size of the total variation. So lots of us make errors that are greater than the modular variation. And the most common errors are making your neck cut too high and using a stem with too much offset. So head height and offset are important for limb length. Calcar reaming and checking for a fracture, and stem insertion. So after performing a trial reduction, always use the calcar reamer. But start gently, because if you force it on, you can fracture the femur. It's 2 important advantages. Number 1, it allows you to check for a calcar split or crack. And it allows you to check for stability. So it's really important with a cement-less stem to use significant force to check to make sure it's stable. And 1 stem in 15, in our experience, at this stage in the procedure, is unstable. If it is, and for example, is a size 11 broach, you simply take out the size 11 broach and go up to the next size up, and it will go down to your neck cut. So never open the definitive stem until you've done this step. So it's critical to achieve primary stability. Stem insertion, it should go down most of the way by hand. If not, remove the stem, check the size, check for bone debris in the canal, and then reuse the broach. However, the most common cause of it not going down is diaphyseal hang-up, and the stem is just a bit too big. And in these cases, it can be also difficult to get the collar to sit flush on the calcar. Also, if the stem goes down the whole way without using a hammer, then you've either a fracture or you open the wrong stem, it's too small. Don't be alarmed in door C femur, because in door C, it will go down to less than 10 mil sometimes, and this is normal. And also in type C bone, reaching the final broach is often more sudden than in a good cancellous bed. So again, critical to get primary stability. Then insert it with a hammer, it should be down, the collar should be down flush in your calcar, And if you're persistently not getting this, then you're getting diaphyseal hang-up, so you're oversizing the stem. Head impaction, leave this protective cover until you're ready to put the head on, and then make sure the taper is clean and dry. Do not trial off the taper. You trial off the broach. The taper should be kept sacred. Then apply the head in a clockwise motion to engage correctly, and then give it a firm hit of at least 4,000 newtons, just once. And the same force for ceramic. So don't be gentle with the ceramic. You'll never break a ceramic head. And the 4 key messages to get the lowest revision rate with the Corail is: number 1, always use a collar. And number 2, avoid size 8 and 9 stems in males, and be cautious of a size 8 in females. Those are the big 2. And the other was what I would be ideally ceramic and cross-linked poly. And again, as I said earlier, maximum head size of 32. Thank you.
So thanks very much again, David. A huge amount of information from a huge amount of experience, and we'll come to some questions about that in a moment. But I'm going to share my screen now, and I am going to just maybe try and put both of those talks together and say that it's acceptable perhaps to sit on the fence. And what I'm going to say is that the answer is in front of you, and my disclosures really are not relevant to this particular talk. And if we're looking to achieve the perfect total hip replacement, one of the difficulties that we have is getting that accurate restoration of hip biomechanics that we started this session talking about. Getting the offset right, getting the abductor tension right, making sure the joint's stable, and make sure that we've restored leg lengths accurately. And the choice of fixation on the femoral side will have an effect on our ability to achieve those goals. And if you get that choice wrong, or get the operation wrong, you can lead to problems with function, with satisfaction, and of course with implant longevity. So when we look at a patient, when we look at a femur, there are certain things that we need to look at. We need to look at the patient's age, the activity profile, look at the anatomy, look at differences in femoral morphology, look at differences in femoral bone quality, because all of these will have an influence on what you choose and how you choose to fix your femoral component to bone. Now, your fixation choice will also be influenced by your training and by your experience. And in these days, we need to make sure that it's cost effective. But fundamentally, we need to make sure that we look at the clinical evidence behind our choices. I think it's also important that you look at the likelihood for revision and how easy that revision is going to be. So if we're looking at young patients, we need to make sure we're doing something that's going to last or could be easily revised. Now, Sam's already shown this slide to show how we've gone from being a cemented through an uncemented sort of nation, and now we see the rise of the hybrid. We're not alone. In other registries too, uncemented fixation has become increasingly popular. But I would argue that getting the biomechanics right is not easy, whatever technique you use. And with uncemented fixation, as we've just heard from David, you really do need to have careful attention to detail to get that right, because implantation depends very much on that proximal femoral anatomy. And it's not that difficult to get things wrong if you don't think about it hard in terms of malalignment, rotation, getting fractures, getting thigh pain, and therefore getting unhappy patients. Here you can see a case we've just heard from David of a Corail stem that's undersized and indeed inverus, and then you can see has subsided, hasn't integrated well, jammed up on the collar and resulted in pain. And here a different situation with an uncemented stem that has been jammed distally with a blade stem. And you can see that because it's jammed distally, it's not loading proximally and it's not integrated proximally. Again, hasn't integrated properly, pain and a revision. So there are other certain circumstances, and these are high-risk patients. This is what a high-risk patient looks like in Nottingham with a relative poor bone quality on the femur. And whatever you do, cemented or uncemented, attention to detail to make sure you get that right is critical. Now, Sam's alluded to this, the obvious benefits of cement in terms of having an ultimate modularity to make sure that we get that biomechanic right. But I think also it's important to identify that cement can also work very well and be helpful in the circumstances of poor bone quality. The versatility is demonstrated by Sam's presentation, and indeed, again, in some demonstrations here of different femoral morphology being dealt with cemented stems. But we need to plan to be versatile. Here I thought I might want to use an uncemented stem. I templated an uncemented stem, a young patient. But of course, with this situation, bone quality was nowhere near what I was expecting. And therefore, we changed that intraoperatively to use cemented fixation to try and get the best outcome from that particular patient. So I would argue that hip surgeons should be above any thoughts of one technique fits all. I think you need to assess each case individually, and you should look at the patient and listen to what the femur is telling you. There's no two ways about it. Cemented fixation has got great clinical heritage. It's versatile in standard and complex cases. It's safe and simple, reproducible technique, reliable in poor bone biology. And I think it's also got fantastic options with regard to conservative revision. Uncemented fixation too, as we've heard, has got great heritage, but it requires careful planning, attention to detail, and Dave has just given us 10 key messages to make sure surgical technique is just as crucial with uncemented fixation. And I think that a lot of the early revisions that we see in uncemented fixation really are technical errors in terms of us as surgeons not getting that side of things right. And the excellent results that you can see from uncemented fixation, I think, reflect excellent technique. So my message is assess each case individually and customize your fixation to your patient. Thank you very much. So I'll end that show there and I'll stop sharing my screen so that we can come back together and we'll start some discussions, I think, really. Pete, we've been doing our very best to answer the Q&As. Jonathan, thanks very much. You've been doing that, and Sam and David too. I've got some questions from the Q&A. So if I start maybe with Sam. Sam, we've got a question here about how do you make sure that we centralize a cemented stem in that voluminous door C type femur? What are your tips and tricks for making sure we get that nice and straight?
So I think it's attention to detail with your rasping at the proximal end. So I talked about rasping into that sort of the posterolateral slot, that sort of trochanteric fossa area, where you can sometimes get that hard bit of bone just below the tip of the trochanter that can push you into varus. I think also it's about recognizing what your trochanteric morphology looks like. Some people seem to have very overhanging trochanters that will push your stem into varus, and actually you almost have to rasp a channel in that trochanter to get the stem straight down the pipe. When they don't have an overhanging trochanter, it's not quite such an issue. I think when you've got a tight canal, that can also sort of push you into varus. I think and recognizing that preoperatively in your planning that the canal is going to be tight. And if you're not able to get the implant in that you think you should be able to, it probably means that your stem and your rasp is going in varus. So you need to work on getting out laterally a bit more to get it straight down. And then I talked about when you put the implant in, again, you see trainees who've worked with other people, they start by putting the tip of the stem where your centralizer is right out lateral because they're worried that the stem's going to end up in varus, so they think they have to start lateral. Well, all that then happens is that the centralizer and the tip of the stem scrapes down the lateral cortex, removing the cement, and actually ultimately ends up in the middle of the femur, because the middle of the femur is a cylinder, whereas the top is kind of an oval. So it's going to end up in the middle of the cylinder. So start it at the top in the middle, and then it'll end up in the middle. Does that make sense? Jonathan's nodding. He knows what I'm talking about. I probably didn't explain that very articulately, but
I think you did. And there's another question again with regard to the cement and Jonathan about swabs. And we've got a question here saying, listen, I've seen swabs, I've seen no swabs, I've seen carbon dioxide wash, I've seen pulse lavage, I've seen all of these things. So what's the definitive message finally on the swabs? Jonathan or Sam?
I think the definitive message really is to wash the canal, and I don't think it makes too much difference whether you use a swab or not. My two colleagues, Matt Hubble, Matt Wilson, they don't use a swab at all, and they have fantastic results. I tend to use a swab soaked in saline because I like the femur to be really dry when I put the cement in. And the other thing I worry about is if you have a suction catheter down the end of the femur and you haven't got a swab there, what I'm worried about is sucking theatre air down through the femur to the end of the plug, and I'm worried about an infection deep down. So I don't tend to leave the suction on an unpacked femur for very long. The thing about hydrogen peroxide, that was an MHRA diktat that came about from a above knee amputation. that got an air ambulance when people soaked hydrogen peroxide. It's a shame because we can't use it. We used to. But yeah, it's not a huge technical thing, I don't think, the use of the swab.
So we're getting some great questions, actually, and a couple here for you, David, before we come back to all of us. I've got a question here about, can you just go through the benefit of the collar with the particular stem or with these uncemented stems that you've talked about? Maybe, you know, you have experience with one, but what does that collar do?
The key thing about the collar is rotational stability. So if you have if the collar is against the calcar at 45 degrees, mechanically it can't turn. And essentially it stops early fractures. And there's very strong evidence from the NJR, now from the German registry and the Australian registry, that the revision rate of uncemented stems is about 0.8% in the first year. And that's predominantly in patients over 70. And if you use a collar, you just stop those. And it is 0.8%. So it's very, very significant. And it's clear across all the registries. So I think now, if you're going to use a cementless stem in all age groups, then you must use a collar. And the other big thing then is the undersizing. So those are the two big causes. And the one you showed, Andrew, the collar doesn't protect you if you undersize. So if the stem's too small, the collar is of no benefit whatsoever.
Yeah, no, it just keeps marching through the bone.
Exactly.
Now we've got another question here for you, David. And in terms of can you go through, I've mentioned some thigh pain there. What are the causes of thigh pain when you've got a patient who comes from somewhere else to your clinic with thigh pain with an uncemented stem? What are your thoughts? And is thigh pain normal? Can it exist for some time and get better? Talk to us about thigh pain.
Yeah. But I think on X-ray, if you see a patient with bone hypertrophy distally, if you see that, that femur is working hard to prevent, so if you get bone hypertrophy around a cementless femur, it means the bone's having to work to hold it. So it's overloaded in that area. But really, we haven't really seen, honestly, we haven't seen thigh pain with a cry. But I think that simple thing of measuring canal diameter, and if it's 10 or less, always reaming. I mean, that does get you out of the tight canal issues. But I think if you jam a cementless femur distally and it's potted distally, and you get overload, then I think that probably is the cause of thigh pain. But with the cry, certainly in Belfast, we really haven't seen thigh pain unless the stem gets loose. But then you do see those X-ray changes then of the bone hypertrophy, and those patients are painful.
So let's go back to our cemented colleague and colleagues. A question that I'd want to ask is to do really with the concern with cement and elderly osteopenic bone and pressurization so what are the tips and tricks to try and avoid any cement implantation concerns?
I think it's about careful preparation. I think bone cement implantation syndrome absolutely exists, and no cementer would deny that. But I think what cementers would say was that actually, if you look after the bone, if you stick to meticulous technique, you can significantly reduce the risk of that happening. Because it's also about pushing fat into the systemic circulation. It's not just about the cement. And that's what I was alluding to with the washing. So, when I worked down in Exeter, I remember Graham Gee saying, you should wash the canal with pulse lavage every time you put an instrument down the femur. So, you start with your pin reamer, you pulse lavage, you then go to your bigger pin reamer, you pulse lavage, you then plug trial, you pulse lavage. You then put your rasp down, you pulse lavage again. So every time you put an instrument down, you're washing out the debris that you've created by introducing an instrument into the femur. You're washing out the fat, you're washing out any debris, and you're reducing the risk of it then being pushed into the circulation. And I think, when you've got somebody who's got really, really osteoporotic bone, I think you just need to be a little bit careful about how much you pressurize. And certainly in hemiarthroplasties, I don't go crazy. I use the pressurizer just to make sure the canal is full and to stop the cement coming out the top, waiting for it to get to the point where I'm ready to insert the implant. Attention to detail and just being careful and washing lots and reduces your risk.
Now, David, washing lots and washing with pulse lavage. Now, would you be careful about using pulse lavage because you want lots of that stuff to stay there and help fix your stem?
Yeah, so we never use lavage in the femur. Yeah.
Okay. Yeah. And in terms of the instrument,
it's different. It's very different. I think Sam's point about if you're, the more concerned you are about pushing nasty stuff into the circulation, the more important it is to lavage.
So I want to come to, no, thank you very much. I want to have time for Jonathan's great cases, but I want to come to one question first, and it's a great question. And it's the question that about what are the final things that we do before we put our stem down, before we put our uncemented stem down? What are the final tests that allow us to be sure that we've got the biomechanics of the hip right, the stability of the right hip right, the leg length right? How do we put it all together during the actual operation? Maybe David, you've demonstrated it very, very much, but before you put your final head in, what's your final maneuver before you close the hip up? Maybe we just ask each of the panelists, what's your regime?
Is this a trial reduction, you mean, Andrew?
Yeah, basically, what is it? You said that you're not going to use you're not going to put another head on top of your trowel. So presumably with the
broach, yes. So the troweling is all with the broach, and then when you test stability at the trial, the amount of movement you have before dislocation is determined predominantly by how much you had beforehand, pre-op. So we measure internal rotation before we open the capsule. And the important thing there is if you have fixed external rotation on the table, which is actually very unusual, then that hip will feel unstable, often at 30 degrees of internal rotation. The message is then, do not antivert your cup, because that patient will come out the front. So you must, to interpret your range of motion of trial reduction, you must measure it before you open the capsule. Then inflection and internal rotation, I want the head to slide out, not to fall out, but to slide out. So inflection, adduction, and internal rotation, if the head is what I call locked, is too tight. And you have to go down again. So it mustn't be too tight, but it mustn't fall out either. But your range of motion you get is determined much more by your pre-op range of motion rather than by where you put your implant. And beware of fixed external rotation.
Fantastic. Jonathan, what would be your sort of final tips to add to that?
When I first put the hip in and reduce it, the first trial reduction, I insist the patient's on the lateral side. I put the leg back on the other leg and watch for movement. If there's a movement to kick at that point, you've got the leg too long. If the hip tends to roll into internal rotation, the offset's probably too high. I like to put the leg back on and see no movement, because that's the first sign that you might have overdone either leg length or offset. I look to see whether the posterior pair comes up and comes up easily. If it comes up too much, you've underdone the offset. If it doesn't get there, unless you've got a fixed external rotation deformity, it's very difficult to get that cup open, or you've got a protrusio hip. Those sometimes don't come back up, but the posterior pair in most cases is a reasonable indicator of whether the offset's about right. Those would be two tips for me.
Sam, can you add to any of that from David and Jonathan?
Not really. I think they've covered most of it. I mean, I think those are the tips and tricks I use as well. I think it's about feeling the hip putting it through a range of movement. I think that kick test is really important, and that sort of the internal rotation when you pull them back into extension is really important. I think that tells you a huge amount about it. Sometimes those patients who've had a really tight hip to start with, they've got a tight capsule from having a flexion contracture, they've become a bit chair shaped. That's sometimes a bit more difficult to use that kick test, but I think it still gives you really good information.
Yeah, just one last thing on the capsule. So the capsule, as John said, is really important. But again, put the hip where it was before you open the capsule. Because if the 30 degrees of internal rotation pre-op, you must put it in 30 to test your capsule. And as Jonathan says, the capsule's a really subtle test. But put the hip where it was before you open the capsule.
So fantastic. I've got to have a tip, because I can't ask you colleagues for one and not come up with something. I'm racking my brains. So one of the things I like to do is I like to use the femoral head that I've resected. I do a lot of intraoperative measurements from the tip of the trochanter, tip of the left trochanter to the center of the head. And I don't let the nurses chuck that off the table. I like to use that, and I'll use that with my trial head as well, just to try and see that I'm putting things back roughly where they were. And I think in terms of your consistency with soft tissue tension, when you do any kind of a shuck test, just make sure the leg's in the same position each time. You see people sometimes flexing and extending and abducting. That will change the soft tissue tension significantly. So be consistent with those sorts of things. So hopefully a few tips for everybody. We've answered as many questions as we can. Jonathan, you're going to put us all together and to try and come back with some cases now to discuss everything that we've come through. Pete, is that all right?
Okay, if I could ask the faculty, keep their cameras on, keep their mics open, and challenge me on anything you want to, and let's just make this a final discussion. I'm going to watch Peter for his hand telling me to shut up. So listen, just a few clinical cases to wrap up and to consolidate what we've been saying. So we're talking about planning hip replacements and, putting the stem in the right place to get the leg lengths right. So here's a bit of a challenge from that point of view. It's very valgus. This guy's 48 years of age, obviously with dysplasia. And I suppose, he's got a lot of left hip pain. He was a very miserable patient. You can just see some lateral cysts there, both on the acetabulum and the femur, but not an awful lot of joint space narrowing, I suppose. So I did a diagnostic injection on him. So I think one thing I would say about injecting the hip, particularly in the degenerate hip, is I don't tend to use steroid very often, mainly because I'm worried that if I get a positive result, but only a short and transitory positive result, the use of steroid would make me worried about future infection in a hip replacement. I have a cutoff of 6 months between a steroid injection and a total hip replacement based on a bit of a literature review. I don't know if any of the panel would disagree. Andrew, what your approach is to steroid and hip replacement?
Yeah, so I'm very conservative too, and I'm probably over conservative, and 6 months is what I will regularly tell a patient. I have had occasions where I've done exactly as you told me not to, and that is I've put some steroid into a joint and had a very transitory response, and then had someone come back to see me a few weeks later, very much worse than they were when they had the injection. And I've had my arm twisted, and I've been a little bit sooner than that. But I think 6 months is what I would speak to the patient about. And I think the local anesthetic diagnostic block is a really, really important test, actually, but I try and avoid steroid.
David, Samantha?
Yes, me too. Yeah. So it's a diagnostic for me as opposed to therapeutic.
So
yeah, I agree. Diagnostic.
Yeah.
But
Okay.
just to say, Jonathan, that's one of the cases in 500.
Yeah.
That patient has a valgus hip.
Yeah. Oh, this
But
guy. This guy has a valgus hip. So
that's the one. That's the one in 500.
No, this guy's got a valgus hip. So,
Yeah.
but the external rotation, what you were talking about, David, the external rotation of these X-rays is overcalling that, and you've got to keep that in mind. And there's some questions about that in the chat.
Yeah. I mean, it'll be different on a CT scan, for example, if you do it true. But it's still he's won the 500.
Yeah. So, you know, with the type of collarless polished stem cemented that I use, I don't normally worry too much about net cut length. We can generally accommodate that with the cement. But going into this sort of case, I certainly want to make sure I've got enough length to support the stem. And so in this case, you know, I measured up what it would look like from the tip of the lesser trochanter to my preferred net cut that's going to give me enough support for that stem for the height that it needs to be. In terms of planning the cup, I'm trying to bring that lower end of the cup down to transverse acetabular ligament. And I would stress what everybody said about putting the cup in the right place, you know, and getting it at the right height, the transverse ligament, in other words. You've got to get the center of rotation right. That's where the heart you start to build the hip from. And, you know, Marcus Banks from Guy's talks about not repeating the valgus hip. And he talks about medializing these acetabulae in a dysplastic hip, and I think that's a good point. So those are all features on the X-ray. Whether they were reproduced in the operation, I don't know. But you can see that the stem has been left more proud. I'm not sure that I did medialize the cup quite as much as I was planning, although I have got down, I think, to the true floor there. But his leg length is restored okay, I think.
So Jonathan, I think this case is fascinating because these sockets, when you've not done many hips, can look a little bit disconcerting when you get into them, because you're very used to that hemisphere and suddenly your anterior wall's fallen away from you a little bit. It looks like a sort of flat plate. And there is automatically a tendency to sort of ream in the middle of it and end up with a slightly high hip center. And using David's point of keeping the reamer in contact with the TAL so that we keep the hip down, there are plenty of ways that we can fill that tiny void at the top end if we need to. But it's quite easy to suddenly end up with a socket that's far too large if you get this reaming wrong. So, you know, going medially, keeping the reamer inferiorly, and then you can pack some graft at the top end if you're going to use an uncemented socket, which I see you've chosen to use there. Again, cement might be a little bit more forgiving from that point of view in some ways. But it's a fascinating case. Can I?
Yes, I was. Yeah. Just so I was saying, you know, don't ream to the true floor. Well, except in dysplasia, yeah. and think, as you say, Andrew, think small. So that the cup should end up smaller than the femoral head in dysplasia. So on average, in a normal hip, your cup should be a maximum of 4 mil bigger, usually 3. But in dysplasia, your cup should be smaller than your femoral head.
Yep.
So think small and go medial.
You can certainly run out of anterior and posterior bone in dysplasia very, very quickly.
Yeah. So as small as you can. And again, I was saying earlier, you know, don't ream above. There's a tendency to start above the towel because you think you're going to go bigger, but every reamer should be against towel. Start on towel and keep on towel.
Absolutely.
Could you do one more case?
Yeah, one more case. Varus hip. Is that okay? Sort of similar sort of thing. So elderly patient, more of a sort of stovepipe femur. We're going to do the right side, a bit protrusio, but you can see here the center of rotation of the femoral head well below the tip of the GT. So we're going to plan this in a completely different way. There's my transverse line across the teardrops, and if we move that down to the lesser trochanter, she's balanced to start with, so we better make it balanced at the end. This is the planning for that case, and you can see here I've used a relatively small acetabular component. It seems to be small in the very voluminous socket that she's got. I'm bringing that center of rotation out a little bit because I don't want to over medialize and reproduce the protrusio that she's got. Here you can see the stem depth of insertion is like 26 mils, whereas before it was 5. So I'm going to have to go for a lower net cut here and in order to get that stem further down. And in order to fill the protrusio, I mean, you can do these sort of hips with cemented or uncemented components. It's not at all a problem. But in this case, I chose to go for an impaction grafting technique. So you know, her socket has been packed up here with impaction bone grafting. if we've got time, I've got a little video on that, but we may run out of time and perhaps come back for another day to talk about the complex hip. But you can see this stem has been inserted well below the greater trochanter. The neck cut's shorter, and I think that the leg lengths are about right. Any comments from any of the others on that?
Yeah, so I mean, these hips are fiddly, and we've got a lot of people who've joined us who maybe haven't done a lot of hip operations solo. So, for me, this case obviously starts with the planning, but technically during the operation, Jonathan, they're not always the most difficult cases, hips to dislocate. And we've got a question here from the audience about short external rotators, and sometimes that it can be a bit tenuous and you can have a problem. So what are your tips and tricks from Sam or from David, and indeed from you, Jonathan, for dislocation and surgical approach here?
Well, I'm happy to start on that. I mean, number one, have a very low threshold for an in situ neck cut with these, particularly in the elderly female, particularly with the wider canal there. We've I've seen spiral fractures given to patients because people are unwilling to do an in situ neck cut in a protrusio. So that would be number one. And the number two thing I would say, it's interesting. I was on a BHS webinar just before this one, and they were talking about these protrusio cups. And they made the point, and I think it's worth making, that I think the sciatic nerve here is at risk. And I think it's important to really understand where your sciatic nerve is. They can be quite high riding in a protrusio hip, and I think you've got to know where that sciatic nerve is and really look after it.
Yeah, I agree, John. So our paper on sciatic nerve, we find no association at all with dysplasia. Our high incidence was females with protrusio, and literally the nerve is pulled in towards the joint. And just a tip on, so that one there will come out. I'm sure you'd agree, Jonathan. But some of them don't. And if they don't, make your neck cut as conservative as you can, because you always take off more neck than you think. So leave as much as you can. Then bring the femur around, then redo your formal neck cut. And then don't try and dig out the head, because it's often fibrosed. So you want that bone for bone graft, so just ream it in situ. And once you get to the shell, then the shell comes out really easily. So don't fight to dig it out. Ream it, and it's held for you perfectly. There's no point in fighting. Just ream it, and then obviously that's your reaming for graft then.
Yeah, I mean, for impaction grafting, I want chunks of bone, so I'll take a nibbler to the head.
Okay.
Same thing. Take the nibbler and take your bone graft then. Exactly.
Yeah.
So, Peter, do you want to Jonathan show one more, or shall we? Are we at time? I can't see you, Peter, so I can't see whether you're raising your hand.
I'm still here. Go on, Jonathan. Have you got another case? Let's do one more case, and then we'll call it a day.
All right. Listen, I think the next case is just to show. It's a bit of fun. Just showing planning in 3D with robotics. So,
okay, that's a nice finish.
I'm just going to scoot through this. This is a case we're going to do the left hip in a female of 70, who's a little bit dysplastic. So she's riding up and out. You can see here in the preoperative, she's a little 3 mils shorter than the other side and 6 mils increased offset because she's riding up and out. And here's the planning case. You can see the center of rotation of the acetabulum plan there in green, the native in magenta, and the femoral head in blue. Of note is the femoral version. She's only got 7 degrees of femoral version. And these are the numbers that I'm planning to make here, that I'm going to accept 5 mils lengthening versus the pre-op hip. Or at least, I'll think about accepting that. I've split the difference between the offsets. In other words, I've gone slightly more than the other side, slightly less than what she started, but we'll see how that pans out during the operation. Like any planning, this is a guide, but it's pre-warning to what you're getting into. The femoral version is important here, I think. So the cup version, you can see this. I've only got this one view, unfortunately, from this case, but you can see that the view from the front, it's tucked in nicely at the front. I can't really go more than that. She's a little prominent at the back, but that's only 18 degrees of cup version. I usually like a little bit more than that. it's just right for her. So I've got to work now on that femoral version because she's only got 7 on the femur, and I need a stable hip. So this is, with this technology, you get what the planned X-ray is going to look like. That's what it's predicting I'm going to look like. And this is the reduction numbers from the first reduction with the rasping. You can see I've got my stem version from 7 to 16 degrees. She's 4 mils longer, which was the planned, 1 increase on the offset compared to pre-op. I tend to use what we've done on the pre-op rather than looking at the opposite side. That was the first reduction. I wanted a little bit more stem version. She would just need a little bit more for stability. So did another broaching, and this is the second reduction. So now we've reduced the hip. She's got a stem version of 20 degrees from 7, combined version of 39, and now we're hitting the numbers. In fact, sorry, this is the numbers after the stem's been cemented in. Now, the technology's got a limit of accuracy of 1 degree and 1 millimeter. So, you know, restored the leg length and offset to what she was pre-operatively, got a combined version that's reasonably good, managed to get the cup in the same position as I wanted to. A bit of sort of fun and probably the future, because I think a bit like mobile phones were in the early 1980s, for those of us who can remember that, you know, these people walking around with these great big bricks, and we thought, oh, that'll never catch on. And now we've all got one. I suspect this sort of technology will be the way of the future coming down the track. And so there's the preoperative plan X-ray prediction, and there's the end result. And they are consistently pretty good at this. And I'll stop there, Andrew, I think.
Jonathan, am I right in thinking that robotic hips are pretty much exclusively uncemented on the acetabulum side?
Yeah. I'm not aware of robotic cemented cups being done. Yeah, it's an uncemented cup.
So yeah, Jonathan, I mean, that's a fantastic case, and quite simply, you know, if we look at it from the point of view of the evening, you know, we're starting off there as you know, with perfection and planning, and you've just finished it with perfection and planning. As I look through this, you know, Sam, you've shown us that there's no mystery in cementing sockets. If you do it the right way, it works fantastically well. We saw calm and consistency with cemented fixation on the femoral side. That's perfect. And again, actually putting uncemented stems in is as simple as it looks, as long as you follow David's 10 rules. So quite frankly, I'm very grateful to Sam, to David, to Jonathan for your excellent talks and for your cases, Jonathan. We've worked our best with regard to the Q&A. I think we've answered most of them. We're very happy to answer more. Really enjoyed tonight, actually, and thanks very much. So thanks very much to you three, and Pete, hand back to you and to OrthoHub.
Cheers. Thank you very much for attending, everybody, for hanging in there. Almost all the participants stayed to the end. Thank you so much. And we've got more stuff coming, which was in the preamble before this, and we'll see you for our next thing. Cheers. Thank you very much.
Thank you.
Thanks, guys. Good night.
Thank
Good
you.
night.
Thank you, Andrew. Thank you, Peter.